Hi, I hope you all are doing well. Welcome to our channel MRCP Made Super Easy. And today we'll be talking about a story, the murder story of potassium actually. Well, some of you might wonder why I'm labeling this innocent potassium as a murderer. Well, there's always a catch in our lectures, and we will find out soon as to why I'm being so harsh towards this potassium. So, if you look at our first picture, we have this two cute looking bananas which represent potassium. And as you know that bananas are a rich dietary source of potassium, so this picture should help you realize that this is an important source of potassium, right? But before we actually get started with today's lecture, we need to know some basics which will help us understand why exactly the ECG changes happen when there is a hyperkalemic event. So once we know that, you will realize that you will be able to understand this topic better, and if you understand this topic better, you will enjoy answering the questions that are asked on this topic in a much better way. So without further delay, let's get into today's story. So once upon a time, there was this cardiac myocyte who was going through a tough time in his life. This cardiac myocyte was so depressed that all he had in his life was negativity. But fortunately for this cardiac myocyte, he was blessed with three friends: Mr. Sodium, Mr. Potassium, and Mr. Calcium. So, one day when the myocyte was resting and feeling quite negative, so negative that if you would have measured how much negativity this myocyte had, it would come to minus 90 millivolt. So we can say that this we will take it as the resting membrane potential. Minus 90 millivolt will represent the resting membrane potential, that is the phase during which the myocyte is feeling so negative that it is minus 90 millivolt. So the sodium was quite upset that its friend is feeling so negative, so the sodium decided to pay a visit. The sodium went to the myocyte and said, listen, I don't like seeing you this way. I want to help you, realize your potential. I want to help you reach towards threshold. So I wish to offer all my positive energy towards you. So by doing this, the sodium started entering inside, and as it entered inside, the cardiac myocyte realized that it was slowly going towards its threshold. And when we measured the threshold, it came out to be minus 65 millivolt. So this way, the cardiac myocyte soon realized that as more and more sodium energy was getting transferred onto this cardiac myocyte, it was gradually losing all its negative energy and it was going towards positivity. What the sodium didn't realize was potassium was already inside, but even though potassium had a lot of positive energy, it was unable to transfer that positive energy to our cardiac myocyte, at least not enough to take it to the positivity, the levels of positivity that sodium has taken it to. So potassium says that, okay, I have had enough of this. The potassium starts going out. It says that, okay, you stick around with sodium, I am going out. As this happens, our superhero calcium enters and says to potassium, okay, you want to feel bad about this? It's okay. I'm going to enter in and I'm going to transfer my positive energy to ensure that cardiac myocyte does not lose out on its positivity. Well, this goes on for a period of time when sufficient amount of potassium is entering out and calcium is entering in. This phase is called as the plateau phase, where cell is not losing too much of positivity nor is it gaining too much of positivity. So there is an equilibrium, there's a balance that is being maintained. Well, unfortunately, all good things have to come to an end. Calcium has its own things to take care of. So calcium says, listen, I have done my best. Now you're on your own, so you take it from here. But as soon as calcium channels close, the cardiac myocyte starts losing all its positivity and it starts gradually coming back to its negative phase. So it comes back to minus 90 millivolt. So I hope that helps. That's the story of our depressed cardiac myocyte and its three friends. Now with that story at the back of our mind, let's go and look at into our today's main topic. Now compare the diagram. What will happen if there is excessive amount of potassium coming in? A poor cardiac myocyte will not have any time to rest. it will be in hyperexcited state. This phase or this phenomena of losing negativity and gaining positive charges is called depolarization. The phase where the positivity is gained and lost at the same time is called the plateau phase, and the phase where the positive charges are lost and the cell comes back to its negative state, it's called as repolarization. So if there is excessive amount of potassium going out and calcium coming in, so if in case of hyperkalemic state, if there's too much amount of potassium here, the cell will not have time to reach repolarization phase. It will be depolarized for a prolonged period of time. Hence the resting membrane potential will rise from minus 90 millivolt to, you could say, around 70 millivolts. So that can cause an exhaustion of the cardiac myocytes. So that's the reason why people with hyperkalemia becomes a medical emergency. Now let's look at the causes. Now since we are talking about murder, someone has to be framed for the murder charges, right? So our first mnemonic for the day, it's called framed. What's frame? F stands for failure. What kind of failure? Well, kidney. R for rhabdomyolysis. Why rhabdomyolysis? Well, in case of traumatic patients where there is injury to the muscle, there is excessive amount of muscle breakdown. Now, excessive amount of muscle breakdown causes excessive amount of potassium, and this potassium is released causing a hyperkalemic state. E stands for Addison's disease. M for metabolic acidosis. E for excessive intake. Let's say somebody is on a banana diet or a high potassium diet, or someone by mistake gave too much amount of potassium, maybe through IV or saline, so that can cause hyperkalemic state. And D stands for drugs. How do you remember this? A, B, C, D. A for ACE inhibitors, A for angiotensin receptor blockers, A for aspirin, B for beta blockers, C for calcineurin inhibitors, D for diuretics like potassium sparing diuretics, and digoxin. So the cause is pretty simple. You need to remember that somebody has to be framed for the murder. F for failure, R for rhabdomyolysis, A for Addison's, M for metabolic acidosis, E excessive dietary intake, D for drugs. And the way to remember the drugs is just do A, B, C, D. A for ACE, ARB and aspirin, B for beta blockers, C for calcineurin inhibitors, D stands for potassium sparing diuretics, and D also stands for digoxin. Right. So since we were talking about murder, now let's see what this murder is all about. The murder is a very important mnemonic because it's going to help us remember the signs and symptoms, what happens when you get hyperkalemic state. So what does M stand for? If you're going to have hyperkalemia, you're going to have muscle weakness. So M stands for muscle weakness. The U of murder stands for urine, which represents either an oliguric state or anuric state. R stands for respiratory distress. D, because the cardiac myocyte is put under a lot of stress, so it's going to have going to an exhaustion phase resulting in decreased cardiac contractility. E stands for EKG or ECG changes, which we will see what they are all about. R for reflexes, which can be either hyperreflexia or flaccid paralysis or areflexia. So signs and symptoms, we have a mnemonic which is very important, which stands for murder. M for muscle weakness, U for urine, oliguric or anuric phase, R for respiratory distress, D for decreased cardiac contractility, E for EKG changes, and R for reflexia, which are two, either hyper or areflexia. Now, once we are done with this, we are going to look at what are the ECG changes that can take place at each value. That is, the normal values of a potassium is around 3.5 to 5 milliequivalent. 5.5 to 6, you have certain changes happening all the way up to 9 or up to 8, you can say, when a sine wave pattern arises. But let's do that in detail first. Right? Then we'll come back to our picture and we will try to revise it. So the first change that you see is there are tall T waves. Now this is a normal ECG. This is a P wave. This is the first positive deflection followed by a QRS complex that is formed, and then you have another positive wave in the form of T. Right? Now the T wave represents ventricular repolarization. Repolarization, remember we said cell losing its positivity coming back to negativity. Well, what happens when there is excessive amount of potassium? More potassium, more positivity. So the phase for the repolarization to happen, it will take a longer period of time for the repolarization to happen because you have more positive charges. Hence, as a result of that, you have tall T waves, and these tall T waves are seen at 5.5 to 6.5 milliequivalent of potassium. This is the first change that happens on an ECG when you have excessive amount of potassium or a hyperkalemic state. So remember, tall T waves, which represents ventricular repolarization. Repolarization means cell is losing its negative charges. So hence here it is not able to lose of negative charges. It is positively charged. So the T wave is positive and it is tall. This is the ECG representation. This is the, we don't have a P over here. This is, there's a QRS complex followed by a tall T wave on the ECG, which is in V3 and V4. Next, let's look at the second change that can happen. The second change, what happens is a prolonged PR interval. Now this is a P, and this is this phase, this part is called the PR complex. So there is prolongation of this PR interval. Look at this over here. The P and R interval is prolonged around 6.5 to 7 or 7.5, you could say. This part happens, and the P represents atrial depolarization. What is depolarization? Remember sodium coming in, that is the phase where it was taking the cell from negativity to positivity. That is called as depolarization. So when the cell goes towards positivity, the first positive charge that is present on the ECG represents the P wave, which represents otherwise called as the atrial depolarization, and the PR interval is prolonged over here. Okay, so look at this ECG again. P, Q, R, S, T. This is the second P, and this over here is the PR complex. Now this PR complex is prolonged. What's the third change that can happen? There can be absent P waves. Okay, why? Again, atrial depolarization. P represents an absent atrial depolarization. So there is a delay in depolarization happening because of a delay in repolarization. So as a result, what is happening over here? The P wave can be absent. So a potassium of around, you could say 7, 7.58 can result in a P wave, absent P wave. So look at this ECG. This is a normal P over here, a P over here. This is the PR complex, okay, where there is prolonging of the PR interval, and gradually you can see that the P wave has disappeared completely, and that's why you see that such patients present you with bradycardia, right? So what happens in delayed phase? After prolonged phase, we look at it. That was, the third was absent P wave, and the fourth one, what's happening now? There is a widening of the QRS complex. This is the QRS complex. This is widened out. Patients will show AV heart blocks, sinus bradycardia, bundle branch blocks, fascicular blocks, and in the worst case scenarios where the potassium is so high, it is 9, which is a life-threatening emergency, you get something called as a sine wave pattern. So this is a sine wave pattern. This is an important MCQ. Do remember, sine wave pattern happens when you have a potassium of anything above 9. Okay, so where there is a conduction abnormality. Okay, now once the ECG changes are clear, so you need to remember the first positive change that happens is tall T waves, then the PR complex elongates, then the P flattens out, followed by widening of the QRS complex, and then you have a sine wave pattern, which is a sure shot death for the patient. So we need to catch these patients when they are in that tall T phase, and we need to correct the potassium rapidly, immediately, because hyperkalemia is a medical emergency. You could lose your patient just like that if you don't correct potassium and if you ignore this. Now how do you treat this condition? It's pretty simple. Now for treatment, we need to divide them into three parts. We need to first stabilize our cardiac myocyte. Remember, the cardiac myocyte is being put under a lot of stress, right? So we need to stabilize it. We need to tell the cardiac myocyte, listen, it's okay, you need to take rest now. So we need to give it something to take rest. How do we do that? Remember our superhero calcium? Well, it has a role over here. So we need to give calcium gluconate 10 ml slow IV over 10 minutes. So 10 10 10, 10% calcium, 10 ml calcium, give it over 10 minutes. Why we do that? Because the onset of this calcium gluconate is at a fraction of a second, like immediate, and the duration, it lasts for 30 to 60 minutes. So it gives us time. The other thing that can be done is give a 3% normal saline, also called as a hypertonic saline, which has high amount of sodium, 50 ml rapid IV push. Again, this also acts in a fraction of a second. Duration is unknown. Next, we need to ensure that we shift this potassium, because there's too much of potassium. We need to push this potassium out somewhere, or we need to shift it till we are able to excrete it. In order to do that, we need to give insulin. Why we give this insulin? Because it is short acting. Now again, our rule of 10 is being applicable here. 10 units of IV insulin diluted in 25% or 50% dextrose solution. Give it slowly over a period of 20 minutes. The onset again, it happens in 20 minutes. The duration, now this gives us a longer duration, 4 to 6 hours. The other one is albuterol or salbutamol. Again, the dosage or rule of 10 applies again over here. 10 to 20 mg. Dilute it in 4 ml of normal saline. Nebulize the patient over 10 minutes. 10% calcium, 10 ml, 10 minutes. Insulin, 10 units given over a period of 20 minutes. Albuterol, 10 mg nebulized over 10 minutes. So 10, 10, 10, 10. Remember that. Onset of albuterol, again 30 minutes. The duration, it lasts for 2 hours. Now, once we have stabilized our membrane, we have shifted the potassium, we need to find a way to excrete, or we need to find a way to push this potassium out of our body. How do we do that? We have Lasix of furosemide, 40 to 80 mg IV. Onset is 15 minutes. Remember, this table is very important. They're going to ask you. Duration is 2 to 3 hours. Soda bicarb, 150 millimoles per liter IV at variable rate. On the onset, it takes hours, and the duration, as long as you infuse, the duration lasts. The next we have sodium polystyrene sulfonate, also goes by a common name called as K-bind. Now there are 2 packets of K-bind, 15 gram, 30 gram. It can be diluted in 15 to 30 ml, 70% sorbitol or oral, and the onset is more than 2 hours and duration is 4 to 6 hours. So these are our permanent solution. But before that, we need to stabilize the membrane, we need to shift the potassium to a place from where we can excrete it out, and then we need to push this murderer out. If nothing is working, if somebody is anuric or oliguric, is not able to excrete that potassium, well, then the final definitive management is immediate urgent hemodialysis. Right, so clear? Now let's look at the questions. This is from Past Medicine, Anki, again Anki flashcards. The questions will be something like this. First line treatment for hyperkalemia. The answer is insulin dextrose infusion. Right? The next question that we can get is based on the ECG changes, where you need to be able to differentiate the different kinds of P wave. Like increased in P wave amplitude occurs in cor pulmonale, whereas absence of P waves occurs in atrial fibrillation or even hyperkalemia. Hyperkalemia, you have small or absent P waves, and a complete absence of P waves is seen in AF. Notched or broad P waves, okay, often pronounced in lead 2, is a sign of left atrial enlargement. We will look at this when we do cardiac, so don't stress upon it too much. So this is just for your information. The next is, when do you go for a renal replacement therapy or hemodialysis? I told you above that if someone is in a hyperkalemic state where he is anuric or oliguric, hyperkalemia is one of the indications for dialysis. You can read through this list right now. We will do this again when we do our renal physiology and pathology and all the diseases related to the renal aspect of medicine. The next is hyperkalemia, again on ECG. You can see this tall T waves. They have asked you about this. And the other thing is hyperkalemia. They have asked you how do you stabilize the cardiac membrane, and we have already answered that, saying that we need to give intravenous calcium gluconate. Right. So these are some of the examples of the questions that you can get. You can get also on calcium polystyrene as removal of potassium from body, which is in potassium excreta. Right. So that was in short our lecture on hyperkalemia. I hope it helped you, and I hope it will help you remember hyperkalemia in a much better way, no matter where you are in your residency, clinical side, you're a consultant, or you're just starting out your medical practice. So that's going to do it, guys, for today. If you think you got something out of today's lecture, then please like, share and subscribe to our channel, and do write to us in the comment section if you feel like you have any doubts, or any particular topic which you guys find difficulty in understanding. So until next time, keep watching and keep revising. MRCP made super easy. We'll see you again next time. Thank you and bye bye.